My talk today, Ellie gave me this title, and when I was given the title I thought, okay, right, yes, what can I tell people like yourselves about ABPI and its importance in everyday practice? And I referred then back to the work, the burden of wound study that Jackie's already alluded to, and the fact that Doppler assessment and assessment of vascular disease was not being done regularly in practice. So perhaps we do need to revisit this and look at the fundamentals and the understanding. So my talk today is to really explore why do an ABPI, why we need to, why should we, look at the rationale behind it, the purpose, the value and the uses. Okay, so let's make a start then and look at the evidence. We've had a lot of talks this morning already talking about the evidence in practice, and I'm glad that Jackie said about a parachute, because to me it's common sense that we should evaluate patients' arterial disease if they have a problem with their lower limb. It seems common sense to me. So do we need a parachute in actual fact or do we need the evidence when it is so much of everyday practice and common sense? So I've based, and when we look at national guidance, it tells us in leg ulcers, in NICE documents, peripheral arterial disease, varicose veins, diabetic foot, and of course pressure ulcer on the heel, all refer to vascular assessment and and how we should assess it. So I'm going to base my talk around these factors. Why do we do a Doppler and calculate ankle brachial pressure index? And this is the basis of the talk, so I'll go through these 7 factors, because this is how I think we should be looking at ankle brachial pressure index in terms of increasing its use in general practice so that we can increase the outcomes and benefits to the patients. You will note on this list that doing a Doppler and calculating ankle brachial pressure index does not diagnose venous leg ulcers. And if there's one thing that gets me a little annoyed when I read the literature or listen to nurses, I did the ABPI, it was 1, therefore it was a venous leg ulcer. We all know that there's many, many reasons why patients have a lower limb ulceration. And all the Doppler does really is exclude arterial disease in that scenario. So let's look at number 1, to assess cardiovascular risk. And there's multiple studies that identify highly significant association between both abnormally high and abnormally low ankle brachial pressure index and cardiovascular disease, and in particular cardiovascular mortality. So when you look at your patient population, if you find a patient with a low ankle brachial pressure index, then arterial disease is systemic. So you have to consider, okay, this patient is at increased risk of cardiovascular disease. So early recognition of vascular disease can in fact save patients' life or limb if you act on the information and the results you get and not just record it. Okay, so, and of course, if patients have got arterial disease, then there's a whole lot of things that should happen as if as second nature. There's a smoking cessation program. They should go on the cardiovascular risk with smoking cessation program, pain control, hypertension control, which is better with ACE inhibitors and not beta blockers. Diet control, weight reduction, lipid management, perhaps statins, exercise program, and of course antiplatelet agents, aspirin or clopidogrel. And we could argue that when you get to a certain age, then most of the population would probably be on a statin and an antiplatelet agent to redress the cardiovascular risk. So it's important because a lot of our patients don't present with cardiac problems. We may be the first person to diagnose it. The set number 2 in my list was to look at or to establish if arterial disease is present. Now, arterial disease is associated with old age, as we all know. So as the population is getting older, so arterial disease is likely to be more common in the population. But it's frequently under-recognised, and patients don't always recognise the symptoms. So we have to look at that in terms of identifying arterial disease. And of course, peripheral vascular disease is a progressive disease, and as the plaque that develops in the vessel develops, so the symptoms become more severe. We know this. And the impact on the patient is increasing symptoms to the point of critical ischemia. But of course, the effect that the plaque has on the blood vessel can have a difference in how the blood flows and the blood rheology. So we need to be aware of that and how we can prevent ischemia. But we have to think as well that ischemia is not a constant factor. Ischemia can develop when cellular demand is greater than available supply. And that may be that the cellular demand is increased or varies with exercise and rest. This increase in cellular activity with inflammation, an increase in metabolic rate with infection, and an increase on tissues and the demand of tissues when there's a wound that requires healing. And we often think about micro and macro circulation, but in actual fact, the available supply or the delivery of oxygen can be affected not just by the circulation. It can be affected by pulmonary function, cardiac output, local biochemistry and oxygen transfer, which of course is more common in diabetics. But of course, when ischemia occurs, pain is the most common symptom, and we know the symptoms of pain on walking and claudication, and that when the plaque develops, then the distance patient can walk is gradually reduced until rest pain develops and ischemic pain. And this ischemic pain is then relieved by dependency as blood flow is simply by gravity and nothing else. And I show this picture here of a lady in a bed with resting her legs out of the bed and typically with ischemic pain. But I always think you don't need to be lucid, you don't need to communicate, and you don't need to speak, particularly to identify ischemic pain, because this is how they will position themselves. So we have to consider what happens to patients with claudication. And although some of you might not be able to see this slide very carefully, if it goes undiagnosed or unrecognised, the outlook for patients over a 5-year period is very poor. And in actual fact, it's worse than cancer. And at 5 years, a patient presenting with claudication or reduced arterial ABPI, 30% of those patients will be dead. 25% will have deteriorating symptoms, and 5% will have an amputation. So if you're diagnosing claudicants or those with a low ABPI today, then their outlook in 5 years is 60% of those will have deteriorating or won't be here. So we should question then whether any of these factors are avoidable. Can we avoid any of these bad outcomes from claudication? And I would suggest that maybe one of the things that I've looked at the past is looking at the patients who actually have an amputation and doing almost a root cause analysis, looking backwards to see where their pathway has taken them to that event, to see whether there's anything in your service that could prevent that. And very often there's something that you could do to help future patients in terms of arterial disease and amputation. So outlooks are poor for these patients with a poor quality of life. Number 3 on my list was to gain information on the severity of peripheral arterial disease. And patient symptoms may not always be a good indicator of arterial disease. A lot of your patients, as well as a lot of mine, with a leg ulcer are not mobile enough to actually get to the point of claudication. So it's not always a good indicator. So feeling pulses is difficult, and it has been demonstrated that it's unreliable, lacks sensitivity when detecting the severity of arterial disease. So a screening tool doing the Doppler and ankle brachial pressure index provides us with a reliable, safe, non-invasive and easily reproducible test for arterial disease. But in order to find pulses, of course, you need some basic anatomy of the blood vessels serving the foot. And as you're aware, there are 3 vessels that serve the lower limb, the anterior tibial, which goes into the dorsalis pedis, where is a very good location to find the pulse. There's the posterior tibial going behind the tibial bone there, and the perineal. Interesting to note that the perineal doesn't reach the foot, so doing the pressures in those 2 vessels gives us a good indication. And you can see the position on this diagram here particularly of the posterior tibial and anterior tibial vessel. Basic anatomy, but it's surprising how many people get it wrong. I'm never always shocked by that. But what about the other information that you can get from Doppler? About listening to the sounds. You can get much more information about the pulse, the location, the nature of the pulse, the quality of the pulse, the rhythm of the pulse, and how many cardiac-associated diseases can you diagnose by just listening and feeling and hearing. You can look at the waveform, and a lot of the new Doppler-associated machinery these days does give you a waveform, and you can get more information from that. You can look at description, pulsatility index, and spectral analysis. But we're more interested in terms of doing ABPI is just doing systolic pressure and, of course, comparing it. The absolute pressure is useful information, and getting the ankle brachial pressure index, and sometimes even the effect of exercise. But Doppler detects movement and the movement within of blood cells. And each artery has its own characteristic signal and pattern of flow. And this one here is typical of a lower limb artery. But here we see the progressive effect of arterial disease of the flow within the blood vessel. The flow loses its triphasic nature as the waveform becomes flatter and the pulsatility index drops and the sound changes. Again, we can get all that information by just listening to the information, for listening to the blood flow using Doppler. So in the a normal triphasic signal The heart kicks the blood out, slows and reverses due to the elastic recoil of the blood of the stretched artery. And at the end, then there's a further sequence which leads to further forward flow. But of course, if you've got patients with arterial disease, as the pulsatility index flattens and the artery becomes stiffer or is affected by the plaque, then of course the sound is going to be different and you lose that triphasic nature. I'm not going to go into too much about the method of doing our ankle brachial pressure index, because I'm sure that Trudy highlighted this yesterday. And the method of doing ABPI is well published. And if there's any questions about that, I'll be very happy to answer them. But it all depends then about accuracy and reproducibility. And that is largely dependent on us all doing the same thing with consistent methods based on those protocols. But it's dependent on the experience of the staff, and everybody knows that the more you do, the more expert you become. And the selection of correct equipment, and just recognise that the ABPI has its limitations. It wasn't meant or designed for use in leg ulcer management. We've just adapted it as a screening tool. But if you use the wrong method or the wrong equipment, then of course it's highly likely you'll get wrong results, which means that the reproducibility is going to be reduced. Then we have to think that yes, we have 3 blood vessels serving the lower limb, but there's also 3 compartments, and those 3 compartments have their own blood vessel. And it's not uncommon that patients may get distal disease in one of those 3 compartments. So we're always encouraged to check more than one blood vessel in the leg. And this gives you more and more richer information about the patient's disease process. Typically we use the anterior tibial and the posterior tibial because that is the blood supply that gets down to the foot. The perineal generally perforates onto the anterior and posterior tibial artery and is really in a bad position to take an ankle brachial pressure index from it. And when you look at a leg in cross-section, the 3 arteries and 3 compartments, but we often just quote one ankle brachial pressure index. And it can be confusing if you have a difference of pressure in both vessels to determine exactly the protocol as to what to follow if the difference is significant. But the arrangement of arteries here can indicate that, or just highlights the fact that there are 3 segments here. And I'm sure the compartments within each leg are served by each blood vessel. And it is, again, not uncommon that one can go down. The use of handheld Doppler in the SFIG remains the gold standard against which all others are compared. And now, as we look in the exhibition, there's a variety of different ways of doing Doppler pressures and obtaining ankle brachial pressure index. But a lot of these, in fact all of them, rely on the application of a SFIG cuff to get a pressure. And if you look at the contraindications of doing ankle brachial pressure index, then it's the cuff that are related to the contraindications and not the probe. So using the probe to listen to sounds can give you more information even without using the cuff. And the complications are related to possible risk of embolus, which is unlikely after 2 weeks, really, or if your patient's mobile, because of course the pressure in the leg from walking is less than the pressure you would apply around a cuff. So dislodgement of clot is a contraindication, as is pain, patients with cellulitis perhaps, or the risk of further tissue damage if the patient has severe ischemia. But if a patient has critical limb ischemia, I think we all recognise that, and we don't need a Doppler assessment to demonstrate it. Number 4 in my list, of course, is our favourite one, is to use ankle brachial pressure index in day-to-day practice as a technique to assess the suitability of compression. Okay. You will note it doesn't diagnose venous disease. It assesses the suitability and the safety of compression. But then what is safe? I know this is a very simplistic diagram that looks at tissue tolerance against ankle brachial pressure index. And as we are normal people, our tissue tolerance to pressure is quite high. And we could have high levels of compression put on our legs, of course, expertly bandaged or expertly applied, and not get any problems. But as the ankle brachial pressure index or arterial disease develops, then of course the risk to the tissue is greater. And we get pressure ulcers, or we could get pressure ulcers under the compression in patients with arterial disease. And that is the risk and the danger. So increasing danger from compression as the ankle brachial pressure index falls. And that may be very simplistic because there's a whole heap of other factors that you need to take into consideration when applying safe compression. There's patient factors, there's concomitant diseases, there's wound factors, there's absolute pressure factors, and there's a variation in pressures between the vessels that you're testing. So it's not as simplistic as this diagram may appear. And what are the risks? Well, these are the risks, of course, and here we have patients with a tissue damage that to me is a pressure ulcer and should be recorded as a safety issue, as a pressure ulcer caused by bandages. How many of you record these on your pressure ulcer safety? Yeah. There's a few, but not all of you, which I'm assuming that is because you never get any of these bandage damage, yeah? Yeah, absolutely fine. Phew. But we do see them, and it's a heart sink moment for everybody, I'm quite sure. So accurate assessment is key, not just of the Doppler, but of the whole patient and everything that's going on. Because without accurate assessment, how on earth can you get a diagnosis, and how could it be possible to allocate the patients to the proper treatment or appropriate treatment pathway? And as we've demonstrated in the burden of wounds study, this is what's happening. Patients are not getting a diagnosis. They're not getting allocated appropriate treatment pathways. So the outcomes are absolutely shocking. And I, as a nurse, is distraught by the results that I found in this burden of wounds study. So we need to think about assessments, diagnosis, treatment pathways, appropriate treatments to improve patient outcomes. And it seems, again, common sense to me. So are the guidelines clear in terms of appropriate pathways? Well, I think they are, really. I think guidelines tell us about the type and urgency of referral. It highlights the risk factors, and we should be looking at cardiovascular risks, complications of treatment, and looking at pressure ulcers on the heel, and when we should be doing ankle brachial pressure index for that. Then, of course, there's the risks of compression, the risks of damage, and the level and type of compression, and what bandage technique to use in order to prevent complications. Now, ankle brachial pressure index can give us a lot of information on gaining information on healing potential. And I highlight a leg ulcer here, but also a pressure ulcer, because pressure ulcers are part of this scenario where we need to be checking ankle brachial pressure index. And these ulcer healing will be delayed and will have prolonged periods of pain, immobility and suffering, which the patients don't deserve. And I think another thing that we highlighted from the burden of wound study was the delay in healing, and that the healing rates were not as good as what have been published in randomized controlled trials. But ischemia affects healing at every level of the healing process, and it would be expected that healing would be delayed if your patient has arterial disease. But we need to think outside or in terms of referral criteria and look at involving the multidisciplinary team, the vascular teams particularly, because non-invasive treatment now can solve this, improve healing and get improved patient outcomes. And the cost of it isn't as much as what you may think in terms of bandaging or dressings. It's the delayed healing that is involved in the cost. And when you think about ankle brachial pressure index or toe pressures and TCPO2 measurements, we can see here that ankle pressures of below 80 associated with 92% non-healing or amputation. Toe pressures of less than 30 associated with 95% failure to heal rate. And a TCPO2 of less than 30 millimeters of mercury, indication of likely non-healing. So we really need to get these patients moving fairly rapidly into the multidisciplinary team so that we can save life and limb, basically. My seventh one is, of course, monitoring arterial status over time. And before you all start taking a deep inhale of breath, and it is a problem, is monitoring arterial status over time, because it doesn't only take resources and time, it is vitally important in some instances. So if we look at the research that has been done, granted some time ago now, it suggested that when an ulcer is present, the ankle brachial pressure index should be repeated every 12 weeks. And that is a big ask of a lot of people in every service, I would suggest. And we need to be fairly clever about how we interpret that information. But it's true, if the patient condition changes, we need to repeat the ABPI. And if an ulcer recurs, then we can't assume that the next ulcer had the same etiology as the last one. So we do need to be a little smarter about this and identify high-risk patients that we need to monitor. And the guidelines suggest those with an already abnormal ankle brachial pressure index, diabetics, those with rheumatoid arthritis, the immobile and the elderly all fit into the higher risk group on which you may want to monitor more frequently. The normal people, if there is a normal person out there, would, with a straightforward venous ulcer, who can report problems, of course, is going to be of a less, in a lower risk category. But we've got to be mindful that healing is best in the early phases, certainly within the first 4 weeks. And we get our best outcomes if we get treatment to the patients as early as possible. So healing best in the early phases after wound onset, so the appropriate time is as soon as possible. And early assessment gets best outcomes if we can do that, reduce healing or improve healing rates, but more importantly, is going to lower the cost. Now, I know Jackie put this up, cheeky girl, the Burden of Wounds study, and I keep quoting this, and it's a very important paper. Well, I think it is, because it gives us a view of what's happening today in real life. But it was quite worrying because there was more than 41% of the wounds were on the lower limb in this study. And this is representative of the whole of the UK. And as Jackie said, Doppler assessment was performed on 16% of patients with lower limb ulceration. 81% of these had compression. But the 84% of patients didn't have a Doppler, okay? And they all had lower limb ulceration of some type. And 46% of these had compression. Now, I'm worried about this because where is the safety in terms of our care? Where are we being safe to our patients? Are we being fair? So my question to you is, why are Dopplers not being done? Is it just down to time? Is it down to skills? Is it down to resources? Or is it down to training? And it's something that you need to think about, not in your practice, but in the people that are surrounding you who are referring the patients in. So, in conclusion, there is a lot of reasons why we should be doing an ankle breaker pressure index. And I think we should be sort of doing it more often because it gives us so much information about the patient, their environment, and how we can help them prevent illness in the future. Thank you very much.